Thank you for joining us for Conversation in Hematology Oncology. During this segment, we will be discussing recommendations to incorporate recent evidence into practice. I am Dr. Gilles Salle from Memorial Sloan Kettering Cancer Center in New York, and I'm joined by my friend and colleague, Dr. Matt Leuning from the University of Nebraska. What we'll discuss today is how the data that have been accumulating over recent months and have been discussed during the ASH meeting will fit into the way we manage patients with follicular lymphoma. So we heard about some targeted agents. There have been approval of agents. Some agents were withdrawn from the market recently. We have had safety data updated for epigenetic modifier, CAR T-cell therapy, bispecific antibodies. Dr. Leuning, how do you see the field evolving? How do you see all the tools that we have in our hands and how we can compare the efficacy and the burden of some treatment for our patients with follicular lymphoma?
Yeah, I think follicular lymphoma is getting to be a crowded space. And when I look at my template and I'm trying to patient template for going into clinic, if I have a fully relapsed refractory follicular lymphoma patient and I know that they're going to need therapy, I got to block out an extra 20 minutes just to go through kind of all the data and all the options. And really it comes down to, patient discernment, right? Making that decision with your patient and having an active discussion. Because yes, we do now have cellular therapy like CAR T-cell, both ACCC and T-cell. And I would assume, based upon the data presented at ASH 2023, that liso-cel is going to enter this mix. You have CAR T-cell, a one-and-done therapy with a high overall response rate and a high CR rate. I think the CR rate, just like in large cell lymphoma, is going to drive the enthusiasm for this therapy. Now, the question is with what price? Not only the financial, potential toxicity, but also the price that comes with some of the side effects. Those side effects early on may be cytokine release syndrome. I think we alluded to and talked about in the earlier segment, I really pay attention more to the risk of neurotoxicity, especially grade 3-4 neurotoxicity, because in an advanced age individual, that grade of neurotoxicity is likely life-altering toxicity, meaning that for the short term, they may end up in a skilled nursing facility or need intensive amounts of rehab coming out of their CAR T-cell. We also have to think about the prolonged cytopenias and the infection risks. I think we've seen further and further data that yes, patients may hang out with hemoglobins of 9 and 10 and platelets between 75 and 125. So their bottoms are not in a chair getting transfusions. But I think one of the things that comes up is, truly what is the risk of neutropenia and then infections. And in an era where infections are kind of within us and all around us, despite our vaccines, we really don't know the robust activity of those vaccines in this patient population. So again, I think that we have to be very choosy around CAR T cells in follicular lymphoma. Speaking of kind of going back to bispecifics, which we know mosunetuzumab, has activity and has been approved. We saw some epcoritamab data here, and we also saw some combination data. What I like about mosunetuzumab in follicular lymphoma is that it is a fixed duration therapy. If you get through the step-up dosing and then you get to, the eighth cycle and you're in a complete response, you can put that back up on the shelf. I think I find that B-cell recovery data sort of reassuring, but I also am concerned about, if that relapse does occur, is that relapse going to be a relapse that I could, give another CD20 antibody to? With regards to its efficacy, I think that it does, kind of speak to whether or not it needs a partner. And I think, lenalidomide, when it is combined with other agents, I think we can use the analogy of tafasitamab lenalidomide, where it appeared lenalidomide was bringing a lot of the toxicity and tafasitamab was bringing, additive efficacy, but not a lot. And I think we're going to see the same theme here when you add lenalidomide to a lot of these agents, whether or not it's EPCO, whether or not it's mosun, as we have seen, driving some hematologic toxicities.
You were talking about duration of treatment, and I think that's obviously an important concern we may have. You have used mosunetuzumab now for a couple of years in clinical trial and in clinical practice. This is a schema where patient will be treated with 8 cycles, 6 months if they reach a CR, and 17, so 1 year of treatment if they are only a PR. In your experience, what are the proportion of patients where you can complete the treatment by 6 months?
Yeah, I think that's, I think that you do get a fair number of patients, probably over half, that can get, put that drug back on the shelf. I think really the data that we're all looking for is for those patients that do have a relapse when you put the drug back on the shelf, whether or not CD20 is expressed and whether or not you can pull mosunetuzumab, back off and achieve the same, response. And then what do you do, right? Is it kind of like a little bit of a resort-based approach, where you kind of do it for 6 months and then you put it back on the shelf, it comes back? And are you going to see, like you do with rituximab monotherapy in follicular lymphoma, the law of diminishing returns, right? While the toxicity may not be there, are you starting to, find efficacy issues? And I think that's really going to be one of those interesting pieces that maybe it's most in single agent the first time, but maybe it's most in len the second time. And I think that's what we're going to miss in the setting of the clinical trials, is really that opportunity to kind of see that we're going to get maybe a little bit of the clinical trial before the horse here, and really trying to figure out where is the best time to add have dual agents or triple, when you probably in follicular lymphoma could get away with just one therapy. I think, Morning Sun trial, those early frontline trials are going to kind of be our first dip in the toe of the water, to kind of say, can you continue to give it second, and can you give it a third, and how do we really count lines of therapy? I think people have debate still about how to count lines of therapy when you're using our monotherapy in follicular lymphoma.
Do you have any concern regarding any other side effect with bispecific? We heard some data regarding infections. Are there any unknown things that are appearing, or is it overall rather reassuring?
Yeah, I think that once you kind of you can get onto autopilot with a lot of these bispecifics, you get through kind of the early step-up dosing. And I think what's interesting about each one of these agents is they kind of each have their own little flavor, right? Whether or not, I know we're not talking a lot about glofitamab, but it comes with an obinutuzumab lead-in, and that cycle 1, day 8, is your highest risk of CRS, versus epcoritamab, where you get to that cycle 1, day 15 dosing. There was some optimization dosing done at ASH 2023 where they really added an extra dose. And it was more so to try and get rid of that grade 3 CRS event. And what you really saw was migration towards grade 1 CRS with that addition of that third kind of inserted step-up dose and the full dose with that fourth dose. And I think that really is kind of an important addition, because I think we all are starting to get comfortable, at least in the academic setting, with these therapies. The other piece that I think we need to add in there is the steroid component. There is steroids kind of given not only with the day of, but also 3 days after with epcoritamab. And I think there's been a little bit of dosing strategy here around, what steroid it is and at what dose. But if you're having CRS on steroids, I think that's a little bit different than if you're having CRS and not on steroids. And I think that's one of the caveats that we have to pay attention to, not only with mosunetuzumab, which from that regard doesn't require hospitalization. And in my mind, it's not using steroids. So if you're having CRS after mosun, what is your management strategy? Versus if you're having CRS on EPCO, your strategy may be slightly different. I think the other piece that we haven't really sorted out about bispecifics is how do we predict who has grade 1 CRS and when they're going to at higher risk for having grades 2 or 3. And I think grade 2 CRS still is something that you have to intervene on, whether or not it is, a slight hypoxia or hypotension in that regard. And so really you have to kind of have a trustworthy patient and a good team to kind of be able to sort through, what patients need to be brought in versus what patients can be monitored.
Yeah, I think that's really a very good summary of how we handle those. And I will say that more and more in our practice, this mosunetuzumab-treated patient with follicular lymphoma are treated, without any hospitalization. We may bring back some patients the day after or eventually late at night, but I hate to bring patients late at night. So, they go with dexamethasone in their pocket, and I encourage them to take them until the next morning when we reevaluate them. And I think most of us will do the same in the near future. And probably the dose of steroids and the quality of the steroids that you said can be optimized to continue to reinforce that. And maybe with the sub-Q formulation, we'll have also some other things. But, you addressed something that was very important, which is, we have CAR-T, we have bispecifics. Both of them are approved right now in the third-line setting after, let's say, rituximab or immunochemo, after R-square. So, what is there a particular sequence you like?
Yeah, I do still put bispecifics in the third line before CAR-T, unless I get the sense that follicular lymphoma is on the path to transformation. And I think that's one of the things that, I think we've learned from, especially from the POD24 data. And one of the things that I educate on is, if you're thinking about relapsed refractory follicular lymphoma, you've got to be, monitoring for that transformation to large cell lymphoma. I think PET scans can be incredibly important. I'm looking for that Sesame Street lymph node. Which one of these does not look like the other? And I think that's key to the, controlling or corralling that disease. You don't want follicular lymphoma to get out of control, and it gets out of control when it is in the midst of transformation, and you're giving follicular lymphoma therapy for really what is a transformed follicular lymphoma. With regards to bispecifics in that area, I think that really for me, I think I have confidence that I can give bispecifics after CAR-T. That's what I've been doing in large cell lymphoma. I think, I can give CAR-T cell after bispecifics, but there's of little data from that standpoint to know kind of a lot of the T cell fitness, manufacturing out of spec. So I think that's what we're going to see probably within the next couple of years at ASH, but I'm not sure that it's going to be in the realm of a clinical trial. I think it's probably going to come in the realm of real world, putting our databases together to try and get this answer. Yeah,
actually, there was, I think, some data coming from Europe and from France or France and other countries looking at that and mentioning like 40 or 50 patients that received CAR-T after bispecific, but the interval between both were quite large. We didn't touch upon all these small molecules that they have been using for years. So can you tell us in a few minutes, first of all, what happened to the last PI3 kinase that was available? And secondly, where do you see tazemetostat, which is approved, fitting in this scheme?
Yeah, I think that, you're alluding to the PI3 kinase class, which we've just seen, be whittled away to, nothing in relapsed refractory follicular lymphoma. And, I think that they're being replaced by other active agents. So on one realm, I'm disappointed that a class has been taken away, but on the flip side, it's being replaced with, I think, equally, if not more effective, therapies. I think the therapy that's going to kind of slide right in there, in my anticipation, is going to be zanubrutinib. I think the Rosewood data, while it wasn't, to my knowledge, presented at ASH, I think looks pretty impressive and is now moving into, randomized clinical trials to further assess that efficacy. I think tazemetostat, is there as a single agent. I just wonder, if I'm going to have to use tazemetostat in regards to as a bridge therapy, if I have somebody that's progressing after a bispecific, let's say in third line. We know that our approved CAR T cells, they don't grow on trees, right? It takes some time for them to get access to it. The vein-to-vein time is still of relevance, and it's a fairly well-tolerated drug. And so tazemetostat as a bridge, I think it could control the disease. I think we are learning that the size of the disease or the volume of the disease probably matters. So even if it's, Guelph criteria type disease, if I can keep it under control, the patient's symptomatic, I may try tazemetostat as a bridge to getting them to their CAR T cell. What I do after their CAR T cell, I think, is also an interesting discussion. Has very high CR rates, and the durability does look good. So I'm not sure there's a place for kind of maintenance tazemetostat post CAR T cell yet. But I think that that's still something where we're exploring in regards to clinical trials.
Yeah, I found this drug very well tolerated, except, some women actually have alopecia with tazemetostat, and which is never encountered with men, which is a phenomenon that is not understood. But, sometimes with patients, you can keep patients 6 months, 1 year with a low tumor burden of disease, a patient who wants to be treated, who may not need, to reach a high CR rate. There is one question, over the years, in the last 10, 15 years, we have seen the description of the architectures, the mutation architecture of follicular lymphoma. We have seen data regarding the microenvironment, the T cells, the macrophages, all these kind of things. Any insight if this guides us into our practice today?
Yeah, I don't, while they end up being great posters or great oral presentations at our meetings, I haven't seen any of them kind of infiltrate into my clinical practice. I think still, one of the things I am looking for is that POD 24, patient. I do believe they do exist. I'm not sure that they're the 20%. And those are truly, those are the bad actors in my clinic. I think there's also the young follicular lymphoma, which I think we have to be very strategic about also, that are being diagnosed in their 4th or 5th decade of life. You're trying to, put a plan in place that gets them to their actuarial, life expectancy. And I think that we're in a realm of being very strategic, but I don't have that magic panel to say you are going to be a POD 24 or you're not going to be a POD 24. And I think we just have to be very conscientious, but not to put our basic science researchers and steer them away from that holy grail of follicular lymphoma, but just know that we're not there yet, in my opinion.
Yeah, well, I think this is very important. And as you said, maybe a few things will come, complicated or simple, we have to see. But the discussion regarding the categories of patients and how we manage them is a very nice segue to the next segment. So thank you for joining us for this segment of recommendation to incorporate recent evidence into practice. Please be sure to click on the landing page of this activity to click to AMA, ANCC, ACPE credit, access supplemental slide, as well as all the topic segments and case scenarios. Thank you for attending this activity.